AC joint.
All right, so up nice and tall. And she's got a nice bump here, and you got a pretty good acromion. Now, usually you're holding the proximal still and you're sliding the distal piece, right? So if I want to do an anterior glide, I would lock this and then move that. I like to check that AC joint. So I'm holding there and I'm looking at see that wiggle. All right?
What are you pushing on?
I've got the acromion. It's coming right around here. So I've got a hold of it and I'm doing that.
Moving the clavicle.
I'm blocking clavicle
Oh,
and moving the
blocking.
acromion.
Okay.
And so that would be an anterior glide of that joint, or I can take it and I can try to pat it out and block it with my thumb and move it this way, and then I'm gliding it there. So those guys are close can see this is moving right there. Okay? Now, in her case, I might want to hold this, set her up a little straighter. I might be able to just move the clavicle on the stabilized acromion. So if I move this way, that's still equivalent to me going this way relative, right? So when I push the clavicle that way, I'm really doing a posterior glide of the acromion. So I could block that. I could try to hold it still here, push that, block here, push that. So in some folks, you can get a hold of the clavicle head here, and acromion limb pretty good, and you can move it.
Is there a reason you want to do one instead of the other?
Just whatever I can grip. Because if this is pretty low level, if it doesn't bump up and it's down flat, I'd have a hard time holding this in. So what's going to drive it is what I can get a hold of the easiest, and what you look most comfortable with doing. Now, if you're making faces with one more than the other, then I'll just work through the other one. So, but it's pretty straightforward. Some people will push down this way to check the inferior glide. Again, oftentimes the problem is not instability at this, stiffness at this joint is instability. Because again, this is where people fall and clip and dislocate their AC joint. Well, if you had a stiff one, if you had somebody who wasn't getting all their range, you thought, well, maybe it's this, or this is not contributing its fair share, then you could come in and see. I've tested this, and I thought, well, that feels the same to me. Maybe this thing is a little stiff. I don't think we're as big a believers of. I think most people think this contributes a little more just because of the way it actually rotates there. It gives you that clearance. But it's possible that this is stoked up in some way. You're not feeling comfortable, something's pinching, and maybe the wiggling makes it feel better and you move better. So I don't go over these again unless I have to. Now the other thing that you can look at is how mobile is their scapula. My thought process is that most people are too mobile in their scapula. Okay? And it isn't a question of true stiffness in that. But every once in a while, someone is sitting around always hunched up, and they don't have much inferior glide, or maybe they're just out here a lot, and they don't really like to go in. But I don't find it to be as big a problem as people often make it out to be. And particularly the frozen shoulder patients, this will often be too mobile. Don't watch for that. We did a range of motion from how the scapula would wing out and so forth. If I'm frozen here and go to lift the arm, then I'm going to drag this out prematurely. And so, because they wanted me to see a frozen shoulder the other day in a clinic, and for some reason this doctor wanted me to see him, and I went and looked at him, and this guy, they have stretched him so hard trying to get this elevation that this thing is just wings way out. The trouble is when you get really stretched out like that, your sense of position is screwed up. You're not setting where you normally set. Your muscles and so forth aren't feeling the tension they normally feel. And so what does he want to do is he keeps shrug and lift, and we can't get that pattern broke up. And I think it's because this is so wiggly that he cannot sense that. So I'm trying to get him to hold in and just move till it starts to go. Try to get him to recruit a normal scapular movement. But right now, it's all that. So that, to me, often is a more difficult problem clinically, someone who moves too much here as opposed to not enough. That said, we will show you a version of this. If you can lay on your side and back down here. Does anybody have a towel or something you can put on a pillow for them? You really want them to be kind of semi-comfortable when you do this.
Oh, no.
That'll work.
so weird filming on this thing. It's like a giant saucepan or
Yeah, I
something.
know.
Like so much.
It's just the battery's so
Look at the
much.
screen,
The
though.
battery's so much better.
I'm
Yeah.
afraid you're gonna drop it.
I am kind of afraid.
We'll drop this up, you know, ouch, hello.
I just some people said like, make sure we get this for Chris, and it'll help everybody else too. So.
Okay, so come toward me a little bit.
It's
Um,
top quality.
Again, what you're gonna look at here.
Don't you like sideline, like on top of
No,
them?
Just go to sleep. Just go to sleep.
But I could look and see, I can move it up and see how that does that way. I can pull it down. I can take it back. I can pull it forward. And obviously, this mobile person from Toledo, I can just lay it all over, right? I can, sometimes if they're guarding on you, you can come in and just rotate them a little bit and just relax and go with it and see if you can get them to do that. Sometimes you may have to trap the arm in a different way if you need to. Typically, this works for me, all right? The one that people always try to do to these people is if her scapula was glued to her thoracic cage and we weren't moving well, you know. The other thing is you get a lot of kind of crepitus and things. Oh, let's make it a snap. Well, they're usually, that's just their scapula's going across those ribs. You know, that's what's happening. But on that person, you could come in and just take them back. And let's see. She's a little hard to get under. There we go. And you can see how much I'm up under her shoulder blade. Sure. This is not a tight shoulder, right? So the people that you can't get under are probably the people that you want to try to get under and distract if they're unglued on the thoracic cage. Alright. So she's mobile. So if you want to do that stretch, the people always try to get in at the inferior angle, take them back a little, let them go over the top of my finger. She's not going in now. There it goes. And now I'm under.
His hand's like
And you can
disappearing.
work that whole medial
I know,
band.
it's really
Now, some people like that just because it's a nice stretch to them. They just think that feels good to have that besides. Other people find that too creepy. They don't like it. So, I don't know what category she's falling in. She's not screaming or
I'm just
anything.
ticklish.
She's ticklish.
Get her phone.
So that is how you could move one around and check the different directions. There's a glide medially, there's a glide into abduction, there's a glide down and up. And the other thing I will say is if it's female and you feel like they're a little bit leery about you being so close, you can put a pillow in between. Right, and that puts a barrier in between things and then you can glide. So that's something else to think about in this day and age. If you feel like they're a little bit iffy, you put something in there and make sure that everything's good. What I usually wind up doing is a control issue. Let's see how good the control she is today. I like to say, this is going to be 12 o'clock, 6 o'clock, 3 o'clock, 9. So take it to 3, 6, 12, 9, 3, 5. That always gets it, you lose the time on. But what you want to do is, a lot of times these people gain control, so they don't know where their shoulder's supposed to go. And so you say depress and all that, but if you get this clock going, then they start going into depression and stuff, if that's what you want. And you guys will learn PNF where you come back here, because the low trap, what do we know? It's kind of hard to test if you have a shoulder problem. So it's laying them down and saying, no, lift your arm and make that the exercise. May not be possible, but so what you see people do in a clinic is say, well, can you bring your shoulder blade down and back here? We'll glide it over to your cheekbone, but you'll push it down and back. So ready, push it down and back. Push it down, push it down, push it down. There you go. Now take it up, back down, down and back. Squeeze it in. There you go. I'll guide you a little more. Down and back. Right into my hand. There you go. Down, all the way. Take it down, take it down. There. And you get coaxed where they start to work that. But it's a nice way to work them without impinging. Because we laid her in her belly, if she had a true shoulder problem, she may not like to do that too many times. This you can, and if I was working at it, it would be on that side. So I could put both hands and she could really work into it. So to me, it's more of a control issue. You can mobilize. So we know how to wiggle these guys. We know how to check this guy out. Okie dokie smokies.
All right.
Good.